I de forrige episodene av Fremtidens sykehus har vi sett hvordan sykehuset Østfold-Kalnes og Nordlandssykehuset i Bodø har tatt i bruk nye digitale verktøy og legemidler for å møte nye behov blant norske pasienter. Men hvordan skal fremtidens helsetjeneste se ut når behovene øker raskere enn ressursene? Under Helselederforum 2026 sto nettopp dette spørsmålet sentralt. I denne panelsamtalen møter vi Meghana Pandit, øverste medisinske rådgiver i NHS England, og Gunnar Bovim, som leder av Helsereformutvalget. Samtalen ledes av HealthTalk redaktør Hans Anderssen, og de diskuterer hvordan Storbritannia og Norge står overfor mange av de samme utfordringene, men også hva vi kan lære av hverandre.
So, thank you for two very interesting presentations. That's great talks. So, and you both outline very ambitious reform agendas, and of course, NHS, you are a year ahead of us.
Exactly.
Yeah, we are still in the planning process and
still struggling.
Yeah, still in work. So I would like to use the next 20 minutes or so to explore what these reforms in UK and in Norway really mean in practice and what they can learn from each other. So now, Gunnar, you have the opportunity to learn a little bit more. Yeah, that's good. So starting with you, Meghana. I find you said that the core political message of the plan is that NHS must radically transform to remain sustainable. Can you just walk us through what is the single most important initiative or the change that really have to happen?
Thank you. So I think it goes back to those three shifts. We've got to organize ourselves in a way that patients have the power. They get the care where they are, pretty much like what Gunnar said. So shift from illness to prevention, shift from hospital to community, and shift from analog to digital. Those three things, if we shift the way we deliver care in that way, we will be able to deliver high quality care for all our people and manage the change that's happening, which was just highlighted. It's the same, right? Multimorbidity is increasing. So the number of people living longer are living longer years or many more years in ill health than in good health. And that's not good. The complexity of advancing technology, which we haven't been able to implement, it's there, but it's not being used in a systematic way. And that could improve patient care.
Yeah. You said that 59% of the British population was dissatisfied with the NHS services. Yeah,
they were.
And you mentioned also that a homeless individual, he has or she has mostly he, I guess, has a 45 years life expectancy.
Yes.
That's more or less the same life expectancy that was in UK for 200 years ago at the start of the Industrial Revolution.
Correct.
So they had lost 200 years, actually.
The male life expectancy currently, who is not homeless, is about 87, 88 years.
Yeah.
So the massive disadvantage for people who are homeless, it just shows, as you said, the access to healthcare is important. The overall functioning of society in terms of, obviously, education, in terms of employment, all of those factors link, obviously, to better healthcare because of the economic changes that would happen in society. So, it's absolutely important to make sure that people are able to access care. So a lot of this plan is helping improve access. You saw that 59% people are dissatisfied mainly because they can't see their GP on time or they can't access a mental health care in time. But when they get there, they're happy with the care they're provided. So we know what the problem is. The problem isn't in what we are providing, the problem is in how we are providing it and how to reach it. And that's the bit that needs to change and improve. The same applies to maternal and neonatal outcomes. So why is there a maternity investigation going on? And that's because there is a complete divide between expectations of mothers and families and the caregivers. So what we have is a very high rising cesarean section rate. So I trained as an obstetrician gynecologist and practiced as one. And up until the early 2000s, our cesarean section rates in the country were at about maximum 22, 23%. Now they're at 50%. So if 50% mothers are having a cesarean section, you can imagine the operational demand and the risks that we are storing up for future years for mothers and babies. And that conversation is not what it, the communication and the risk analysis and understanding is not what it was. But if you look at the data, the number of stillbirths and perinatal deaths is at the lowest it has ever been. But there's still an issue, and there's still an investigation. So it just shows that the dialogue or the expectations of patients, but also the dialogue between caregivers and patients needs to change. And that's why involving all the people, like you are, in giving their opinion and saying what is it they want, how do they think this will change, makes a better impact on the change. Because you've got people who are then participating in the change rather than being bystanders in change.
So Gunnar, Meghana said that there are three important shifts in UK. It's a shift from hospital to community, from analog to digital, and from sickness to prevention. How does this resonate with the Norwegian situation and the proposed strategy that you will come to the government and the Storting with?
It resonates quite well. Maybe not 100%, but I'll come to that. It resonates quite well. And we can listen to the numbers in Britain, but the numbers in this city is that if you live in the eastern side, you have a 13 years lower life expectancy than if you live in other parts of the city.
Exactly.
So we have the same problem, and it's not decreasing.
So we have talked about this, I think, for 30 years.
Yes.
Why is that? Why is people at east of the river has a 10% less life expectancy?
You shouldn't ask me. You should ask this audience. Why haven't you solved this?
Yeah.
And this is within this city.
Yeah.
Between northern Finnmark, the rural areas, it's still the same. And we have it every year. And that surprised me in Denmark, where the distances are not at all. There are no distances, but they still have the same gradients. If you live in the northwestern part of Jylland, you have the same life expectancy as in Finnmark. You have the same recruitment.
So don't live in the north end, then.
Don't live in the north. it's
so
even colder.
I think the problem is also in coastal areas.
Yeah.
And I think it's linked, from certainly our perspective, is people don't want to go work there because they want to work in the city.
Sure.
So
they don't want to work rural.
And
in Norway we have
the
the salmon production, so they are very rich in the coastal part. So
they want to live there. Yeah.
But then do we have the same? Yes, we have the same from hospital to community. And we have the same from analog to digital. We are discussing everybody would argue that prevention is important, and prevention is important. But will it reduce the healthcare demand? That's a really interesting question. Because we live longer, we survive the diseases we prevent so that we can live with it. But as long as the mortality is still 100%, there's going to come an end there, and the resource situation is maybe not that much changed if we live longer. We're all for it. We should do more of it, but we shouldn't say that this is a way to reduce the health cost or the health service cost. Because I don't know whether it is.
Yeah, you haven't said it today, but you have said it several times before. I have heard that Norway, we run out of health professionals before we run out of money.
Yes.
Do you stand with that?
Yes.
Yeah. Is that the same?
Why is that?
Is that the same problem?
Too much money.
So very interestingly,
Yeah.
we saw a huge difference in before and after the pandemic.
Yeah.
So we grew our workforce like a straight line, vertical straight line, but our productivity went down.
Exactly.
And our productivity in 24-25 grew by 2.7%, but it is still 7% below the productivity we had in 18-19 before the pandemic.
Exactly. Yeah.
But the workforce numbers have gone up. So we have had quite an open international recruitment campaign. Because we had difficulties in staffing our wards in hospitals, in community services, we had international nursing employment for many years, year after year, for at least 5 or 6 years in England. So we have a very, very, very large workforce now. Despite that, we had a very high reliance on agency and bank staff. Do you know what I mean? Agency, locums.
Yeah.
And
Same in
people
Norway,
doing
actually.
extra work and bank shifts. So the cost was going up, but the productivity wasn't going up.
Exactly.
So we worked very hard on reducing almost, we saved something like billions, more than 10 billion, on completely reducing agency staff. But we are not able to reduce bank staff because sickness rates are up to 6% in staff.
In Norway it's 10 actually.
Yeah. So I'm giving you the average. So 6% sickness, plus dissatisfaction and demotivation, plus issues with, you may have heard, we have issues with industrial relations. We have doctors striking, we had nurses striking in 2023. So and that's why this workforce plan that we are developing, along with that standard of workforce, of making sure people get warm food and drink, there is no racism, there is no sexual harassment, there's no bullying. That is very important for us, because what that will do is that will engage the staff in developing and delivering the care. Quality improvement is about staff knowing what best to do. I don't know what's best to do in their environment. They know what's best to do. And my job is to say, yes, do it, facilitate it, to make them do the change. But in order to get to that point, we need staff that are healthy, staff that are satisfied, and staff that like to come to work. And we've got to go some ways to developing that.
Just ask you a question, and you can respond as well, of course. The productivity that Meghana mentioned, 2% increase is the ambition, you said. In Norway, what's the productivity rate in hospitals?
The productivity rate is, the big picture is that it's quite stable. It's not increasing that much. There are differences. I'm proud to say that in Oslo University Hospital we do increase the productivity these last 5 years quite some. But it's, the big picture is that it's quite stable. But we have
stable, not in a good way actually. It's negative. It's zero. That's not good.
No, we have to increase it. But I really agree, we have to make it attractive to work in healthcare. We have to make it especially attractive to work in the municipality close to where the patient lives, where the hierarchy of within healthcare is that it's best to live to work. You're the best doctor if you work with very specialized things, but the most important are the generalists. We need to give higher priority to the generalists all over in every profession, because that's what we really need.
So in UK, there is obviously a financial problem to fund the NHS. It's been for several years, but that's of course a problem that is kind of being amended at the moment, I guess. But there is also, as you mentioned in your presentation, an organizational problem. Could you just elaborate a little bit? What are the organizational issues and problems that the 10-year plan now is addressing?
When you talk about organization, do you mean the structure?
Yes, structure, exactly.
Okay.
Yeah.
So the operating model and the structure.
Yeah.
So we have, as I said, 205, imagine 205 hospital trusts, a lot of primary care providers, and then the trusts are providing care that's required and requested by the integrated care boards, and that is being overseen by a region. So what it used to be was there was quite a mixed landscape between who is performance managing the trusts? Is it the Integrated Care Board or is it the region? So we've simplified that. Who is the absolute strategic commissioner? We've simplified that. It is the Integrated Care Board. Do they have the knowledge, the skills, the capacity and capability to commission, right? Well, that remains to be seen. We've got to get that done, okay? But if they commission the services that their population needs in the right way and the right funding, then it's up to the provider to deliver it. What we used to have was basically people submitting deficit plans year on year. And then if they make a deficit, they were being supported to cover that. That's not going to be the case anymore. There's going to be, we've done a medium-term plan. So all providers have been asked to submit 3-year plans now. So for 26, 27, 27, 28, and 28, 29. That's what the funding is for up to now. So we need to understand how providers are going to maintain financial balance or make a surplus. If they do well, they will be given the autonomy and more funds right at the point of clinical teams, not just as a whole hospital. If a clinical team delivers good outcomes, they will get incentives, financial incentives to do better. So those are the reforms. In terms of primary care, there was a big, big problem with access to primary care. We used to call it the 8 a.m. scramble, which means you wake up in the morning, if you need a GP, you get on the phone. You could be on the phone for an hour waiting for somebody to answer or to get to a queue. And when you get to the queue, they say, you have an appointment in 25 days, but you're sick today. So we are basically eliminating that by improving online access. You go onto the site, you put in your thing, you get a response to say, okay, you're urgent, you get to see a GP today, or the GP will phone you to answer your problems.
Exactly.
So lots of ways that people have to work differently and lots of operating model change, but not structure change.
So Gunnar,
I agree in everything.
I guess you would. So many argue that Norway's main problem is the, and I think you mentioned it in your presentation as well, is the fragmentation between municipalities and hospitals, which is obviously was and still is a problem in the NHS. So what kind of single structural change will make the biggest difference to if you actually dare to do something about it? But because this is in Norway a political minefield, isn't it?
Yes, I know.
Yeah. So we're sailing into the Bermuda Triangle, or can we?
The fragmentation is a major problem. The problem is, in addition to that there is both fragmentation within the primary health care and the hospitals, and between them. So if you have a good idea on how to solve this, our email is open.
Yeah.
Because that is a major problem.
Yeah.
And you asked, you increased the number of personnel, yes, and that you could do that in Britain, and you should do it at the point of the pandemics. In Norway, we have just the double number of nurses as the EU mean level, and we have a lot of more doctors than any other European country. We have a problematic geography and everything, but we have tried to put many resources, personnel resources into it. And the question is that the best answer to increase even more?
Yeah.
Why do we have more Swedish nurses in Norway than we have Norwegian nurses in Sweden, when they have a lot less nurses in Sweden?
So you're asking for, I don't know. so you now say that everybody in this room and others, they can try to solve this puzzle, this Bermuda Triangle problem for you?
Yes.
Yeah.
Please do.
Yeah. But you are heading this commission.
Yes.
So what do you think?
I'll solve it by November 1st.
That's great. It's one minute left, guys. I just want to ask you a quick question. If you are going to advise the health leaders sitting in this room, which one decision should they make in this new year, and what decision should they stop doing?
I would say be kind to each other and deliver compassionate care. Because understanding patients and listening, truly listening to patients, enables you to deliver the care that's right. What should they stop doing? They should, it's difficult to say what they should stop doing. If it was in England, I would say stop thinking about why something is not better without contributing to it. Try and make improvements, be involved in the change, and be making the improvements yourself.
Gunnar?
I think in Norway that we should have an honest conversation on ethics of proximity towards the consequentialism. We should discuss that everywhere in the healthcare, because we need to know that it's not economy versus medicine, or the good things versus the bad things. It's different kind of ethics, and we have to increase the discussion about that. And then we should stop controlling all the patients every half year. We should do that personalized, on demand of the patient.
Thank you, both of you, for a great talk. Thank you for and